Good evening, viewers. My name is Rahul Desai, and hereby welcome you all to today's milestone in our journey of 52 weeks of Diabetes Essentials, Dr. Sanjay Kalra sir. These online modules are an educational initiative from Enazal Zero and in memory of Dr. K. K. Garwal sir. Dear viewers, the module which Dr. Kalra sir will take us through today is one of the most important topic with pre-existing medical conditions such as diabetes, heart disease, and asthma appear to be more vulnerable to becoming severely ill with COVID-19 virus. When people with diabetes develop a viral infection, it can be harder to treat due to fluctuations in blood glucose levels and possibly the presence of diabetes complications. And so, before I hand the platform to Dr. Kalra sir to take us on today's topic, that is diabetes and COVID, let me have the opportunity of announcing the names who have answered the quiz questions correctly in last episode. And the names are Dr. Sri Prakash Pandey, Dr. S. Pandey from Chhattisgarh, from Delhi, Dr. Sumita Sharma, from Gujarat, Dr. Jitendra Kumar Shah, from Haryana, Dr. I.C. Garg, from Jharkhand, Dr. Gautam Datta, from Karnataka, we have Dr. K.M. Prasanna Kumar, Dr. Ajit Kumar Hegde, Dr. Ravi Bhatt. From Punjab, we have Dr. Sanjeev Puri, Dr. Namrata Puri. Then from Maharashtra, we have Dr. Girish Gesota, Dr. Hitesh Vora, Dr. D.G. Parmar, Dr. Ashirwad Pawar, Dr. Jagruti Dabhuwala, Dr. Lalita Bhatt, Dr. Pratap Parkar, Dr. Naina Seth, Dr. Kaval Saluja, Dr. Vandana Pathade, Dr. Sanjeev Desai, Dr. Sanjay Kanoje, Dr. Suman Agarwal, Dr. Anupam Agarwal, Dr. Pradeep Gavit, Dr. Harsha, Dr. Subhash Panpalia, and from Uttar Pradesh we have Dr. Irfanullah, Dr. Sanjay Mehrotra, Dr. Suresh Kushwa, Dr. Ashwini Kumar, Dr. Arun Kumar Garg, and Dr. Vikas Tandon. So congratulations to all the doctors who have answered the quiz question correctly. And with this, I hand over the platform to Dr. Kalra sir. So over to you.
Thank you, Rahul, and good evening, everybody. Last week, if you remember, we spoke about an infection. We spoke about tuberculosis and diabetes. And we said that we keep on speaking all the time about vascular complications, about chronic complications, but we don't talk about acute illnesses, illnesses that that form the bulk of all the challenging medical situations that we face in our clinics. Yesterday, we spoke about tuberculosis, which is almost endemic to our country. Today, we'll talk about something that is an epidemic, and we'll talk about diabetes and COVID. It is important to know about diabetes and COVID because many times our patients talk to us about this. Look at the challenging situations that I faced in my clinic this week, and they are exactly the same challenges that we all face across the country. I had patients coming in with high glucose. They never agree to take insulin. They never agree to get their drugs intensified. Sometimes I get angry, sometimes I get frustrated, sometimes I just give up. But now, when this lady came and said, with a glucose of 400, she'd never been worried before, but now she said, Daksab, there is so much of COVID around me. Do you think I'll get COVID? Then my answer was, you have uncontrolled diabetes. There is a risk of developing COVID. But if we get your diabetes under control, if we start insulin, then we can certainly protect you against severe COVID. And that was enough for the lady to accept insulin therapy. The very next patient was someone with a glucose of 250. Sir, can I take my COVID vaccine? From inside me, I wanted to scream out loud, Madam, what have you been doing for the past 1 year? Why haven't you taken your vaccine so far? You should be at the very front of the queue if you have diabetes. But still, she hadn't done it, and there was no point in arguing about spilt milk. So I said, yes, you must take COVID vaccine because it will protect you. And actually, you should be at the front of the queue. You need it more than other people who have better immunity. So I was able to motivate the patient to accept vaccine based upon the diabetic status. These are the kind of challenges that we face in our OPD. Sometimes we face other challenges as well. Someone has developed COVID, and after that, hyperglycemia. How do we manage? Yet another person has developed COVID and then has been started on corticosteroids, and then that has led to new onset diabetes, steroid induced hyperglycemia, or has worsened pre existing diabetes. How do we handle that? These are all challenges that we face in the OPD every day. But to put things straight, let's consider these things one by one. Individuals with diabetes are certainly at high risk of all infections, especially pulmonary infections, especially influenza and pneumonia. This statement, however, is not fully complete because the right statement will be individuals with poorly controlled diabetes are at very high risk of these infections. But if you control the diabetes well, you can reduce the risk of infection. This is why we repeatedly keep on harping upon the concept of glucovigilance. Be vigilant about your glucose. And glycemic hygiene. Keep your glucose under good control. The same way that you practice social hygiene or personal hygiene or vaccination hygiene, the same way you must practice glycemic hygiene. We should also be aware, just like we said, that people with severe diabetes are at greater risk of developing severe COVID 19. Those people with diabetes who develop who develop COVID 19 will end up developing a severe form of the disease, will require hospitalization more often, will require oxygen more often, will require ICU stay more often and for a longer period of time, and unfortunately will succumb to the disease more often. But there is a bidirectional link as well. It's not just that uncontrolled diabetes is contributing to uncontrolled COVID 19. COVID 19 per se, the virus per se, does lead to worsening of diabetes symptoms. It leads to worsening of diabetes control, and it can actually induce newly diagnosed diabetes. Let's discuss these topics in greater detail. We are already aware of the impaired immunity that characterizes diabetes and poorly controlled diabetes, both humoral and cell mediated. And because of this, there's an increased susceptibility to COVID 19. And when COVID 19 infection does come in, it acts like an uncontrolled pro-inflammatory insult. When we have this pro-inflammatory insult in the body due to the COVID-19 virus, there are increased cytokines. They lead to defects in the lung. This lung defect, lung damage, leads to overall mortality. At the same time, the COVID-19 virus leads to increased production of reactive oxygen species and interleukin 6. This directly leads to hyperglycemia, and the hyperglycemia worsens lung damage. Hyperglycemia itself is a prothrombotic state, and associated with the prothrombotic effects of COVID 19, and also along with the vascular endothelial damage that occurs in COVID 19, there is an increased risk of CV events, and finally, increased risk of CV mortality and also all cause mortality. So, multiple factors playing out in the milieu of the blood, all disturbing the homeostasis of the blood of the body. Because of the increased release of reactive oxygen species and interleukin 6, there is insulin resistance. And this insulin resistance increases the chances of developing diabetes or worsening of diabetes. Not only that, though COVID 19 actually attacks the pulmonary cells, it can attack the beta cells as well. And because of that, we are seeing an increased risk of type 1 diabetes after COVID 19 infection. While this is true for COVID 19, it is not true for other related viruses. So, we will find many anecdotal reports which say that the risk of diabetes, including type 1 diabetes, has gone up. Worsening of diabetes is quite frequent. Thyroiditis has increased. And many people who had been earlier controlled uh, with their Graves' disease have come back now with relapse. How do we manage diabetes before, during, and after COVID 19? Now, before COVID 19 infection occurs, For every high risk patient, which would mean I think each and every Indian is at high risk of infection, we must control glucose properly. This is glycemic hygiene. Follow whatever guidelines there are. There will be no change in the choice of drugs or in the target glucose values. In fact, if required, you can prescribe insulin because insulin has an anabolic effect and will be able to control glucose faster, will be able to prevent the patient from developing severe infection. COVID 19 vaccination is important. Each and every person, irrespective of glycemic status, should get the COVID 19 vaccine. The only contraindication might be someone in DKA or ketonuria, or somebody with a very bad diabetic foot, somebody with a severe acute illness, which you know will resolve within the coming days or weeks. So we just wait for it to resolve and then send the patient for vaccination. Now, if the patient develops mild COVID 19 disease and is not hospitalized, the definition of mild is based upon respiratory rate and upon SpO2. So if patient doesn't have tachypnea, patient has normal oxygen saturation, patient is at home, you will continue diabetes therapy as per guidelines. Feel free to continue whatever is being given if glucose levels are normal. If glucose levels are slightly high, you might want to titrate doses of existing drugs instead of experimenting with a new one. If, however, glucose levels are very high, you may wish to intensify by adding a new class of drugs. If the patient is being started on corticosteroids for whatever reason, maybe patient has moderate COVID-19 disease and is hospitalized, or perhaps is being treated at home in isolation, and the patient has good glucose control, then we continue whatever we are giving. If glucose control is poor, we must intensify. Do think of insulin, preferentially in such patients, even for a short period of time. And especially if the patient has been put on corticosteroids and they are causing steroid-induced hyperglycemia, then insulin would be the best drug to begin. Do remember that if your patient is on prednisolone or on methylprednisolone, the highest glucose values will be post-lunch and pre-dinner. So we will need an afternoon dose of insulin. In case glucose levels are not very high, you might be able to get away with an afternoon dose of short-acting sulfonylurea, or an afternoon dose of repaglinide, or an afternoon dose of acarbose or voglibose along with metformin. If the patient is hospitalized in the ward, then the treatment of choice is insulin, ideally basal bolus insulin. But if nursing support is limited, then premixed insulin can be given, provided the patient is eating adequately. If patient is admitted in ICU, then there is only one treatment of choice, and that is continuous insulin infusion, intravenous. However, many times last year, we have had to start intramuscular insulin when we were treating patients at home. Patient was living far away, not able to come to hospital, or no hospital bed was available, and patient had COVID-19 and was in DK, diabetic ketosis, or DKA, diabetic ketoacidosis. In such a situation, intramuscular rapid-acting insulin can be given every 4 hours. Do note that IM insulin is not a treatment of choice. It is a treatment of innovation, of jugaad, of improvisation, only if IV insulin is not available. The facilities for IV infusion are not available, or the facilities for IV infusion monitoring are not available. It's only then that you will use IM insulin. IM insulin will never, never, never be a substitute for subcutaneous insulin. It can be a substitute for IV insulin in resource limited settings. Now, these are international guidelines that we are sharing. One difference between these and the Indian guidelines is that in Indian guidelines, DPP-4 inhibitors are given place of pride along with metformin. So if you have someone with newly diagnosed diabetes or newly worsening diabetes after COVID-19, the drug of choice is metformin plus gliptin in India. In general, we have spoken of glycemic hygiene to prevent COVID-19 and to prevent severe COVID-19 infection. But let's add to that. First of all, of course, glycemic hygiene. Then metabolic hygiene, stabilize all other parameters. Immunonutrition, which means uh, You take adequate care of nutrition, give adequate calories and adequate proteins. A person with COVID may need up to 2 grams of protein per kg body weight to ensure anabolism and to prevent catabolism. In immunonutrition, it's not enough just to focus on macronutrients like protein and energy. You also have to look at the micronutrients like the minerals and vitamins. Don't give too little, don't give too much, because if you give too much of vitamin C or too much of zinc, that comes with its own baggage of problems. Exercise done in a safe manner without exposure to infection can certainly help in improving immunity. In closed spaces like gyms, where people sweat a lot, where people breathe heavily or deeply, the droplets can spread far, and that might expose you to COVID. So be careful. And remember to take all your vaccinations in time. Of course, general measures like social hygiene and personal hygiene cannot be overemphasized. Do remember that in COVID times, people with diabetes should continue their glucose lowering therapy. And if they're taking a lipid lowering drug or an antihypertensive drug, that should be continued. uh, Delicate balance has to be maintained, and one should ensure that we avoid hyperglycemia. At the same time, we avoid hypoglycemia. So, based upon uh, the nursing support, the family support that is available, based upon that, we should be able to craft the right regimen for our patients. Today, we've discussed COVID 19 and diabetes. Let's see what questions we get from the audience. Yes, last week we discussed tuberculosis and diabetes. And the questions that we asked was, which of the following first line antibiotics are usually not helpful in Mycobacterium tuberculosis? And the answer is rifampin and ciprofloxacin. Which is the only nutritive sweetener made from sucrose with unique properties? And the answer is sucralose. Our questions for this week are, which of the following are possible pathways that might increase COVID 19 susceptibility? Increase susceptibility to COVID 19 in persons with diabetes? Is it drug induced ACE expression or dysregulation of the renin aldosterone angiotensin system? Is it impaired immunity or impaired furin levels? Or is it A, B, and C or A, C, and D? So let's see what answers we get. Which of the following increase susceptibility to COVID 19 in diabetes? Expression of ACE, dysregulation of RAS, impairment of immunity, increase in furin levels, or is it a combination of A, B, and C, or maybe a combination of A, C, and D? Our second question is, which of the following statements is correct? Persons with obesity and COVID 19 who are under home care and quarantine should be checked for risk of malnutrition and advised regarding nutritional optimization. B. Fluid defects due to nausea, vomiting, and/or diarrhea make hydration and nutrition play an important role in management of COVID. C. The optimal liquids for COVID 19 patients are clear liquid beverages with calories and protein and also ORS. Or is it all of the above? So let's repeat. Obese COVID 19 patients should be checked for risk of malnutrition and advised regarding nutritional optimization. B. Fluid deficits in COVID 19 must be managed with hydration and nutrition. C. The optimal liquids are clear liquid beverages with calories and protein and ORS, or all of the above. This is a very important topic because right now we are grappling with a resurgence of COVID 19 in our country. And we honestly do not know the future, what the future holds for us. And because it's an important topic, we have a lot of questions today. Dr. Bharat Praveen says, we are seeing a lot of patients with normal HbA1c and with high blood glucose. How to categorize these? It can be either stress-induced diabetes, that will be our first diagnosis, stress-induced diabetes, stress-induced hyperglycemia, sorry, that is the correct word, stress hyperglycemia. And it might be, if your patient is on steroids, steroid-induced hyperglycemia. We can counsel the patient that as of now, it seems that you have got diabetes suddenly. Let us see what happens. We will repeat your HbA1c after 6 weeks. Dr. Mehta asks, does diabetes exacerbate only due to beta cell dysfunction? So, beta cell dysfunction will occur in a lesser number of patients with COVID 19. It is insulin resistance that is ubiquitous. Increase in insulin resistance will occur in virtually everybody with COVID, whether it is mild, moderate, or severe. Dr. Bhavini queries as to why diabetics are considered more risky, uh, more susceptible to COVID 19 in comparison with other comorbid conditions. The answer is immune deficiency in uncontrolled diabetes. The diabetic patients are unable to mount an adequate immune response against COVID 19. Also, people with diabetes are already having a lot of comorbid conditions and a lot of concomitant therapy, which makes them more prone to various diseases. And what Dr. Vijay Khedkar comments is correct. People with diabetes and COVID 19 certainly have greater chance of mucormycosis because the immunity comes down markedly. Dr. Girish Kesota asks about repaglinide in COVID 19. We can continue. Now, repaglinide is a short acting secretagogue. You give one tablet with one meal. So, if your patient is taking one meal a day, it will be one tablet. 3 meals a day, three tablets. And if your patient takes irregular or erratic meals, which is common in COVID, then you just give repaglinide along with the meal. Suppose patient is suffering from COVID and has less appetite. You can tell the patient whenever you take a chapati or rice, then you take repaglinide 1 or 2 milligram along with metformin. And if you are eating a non-carbohydrate meal, maybe patient is just drinking a glass of milk or taking maybe a small fruit or maybe taking some cottage cheese or paneer or soup, then the patient can skip repaglinide. Repaglinide cannot be given along with sulfonylurea. It can be combined with each and every other drug. Repaglinide also should not be given along with rapid-acting insulin. So, suppose my patient is taking premixed insulin in the morning, premixed insulin at dinner. Glucose levels are a bit on the higher side. I want to add a lunchtime rapid-acting insulin, but patient resists. She says, I don't want to take a third injection. Then I can add repaglinide at lunchtime. But it would not make sense for me to give rapid-acting insulin and repaglinide together with the same meal. I can give it separate meals. The reduction in HbA1c with repaglinide is quite good. It is similar to that with sulfonylureas. And you can prescribe it as long as the patient has an erratic meal pattern. After that, if patient wants to continue, we can go ahead with repaglinide. If patient wants to reduce, patient is on 3 doses of repaglinide every day and patient says it's too much, you can always change to 2 doses of glimepiride or glyclazide. Dr. Hitesh Vora asks about steroid-induced hyperglycemia. So each patient is different. In general, the dictum is that if you're giving up till around 12.5 milligram of prednisolone per day for up to 20 days, that is 3 weeks, then you don't need to worry. This is a general dictum, but each patient is different. If you are giving more than 12.5 milligram of prednisolone or methylprednisolone equivalent, or you are giving it for longer than 3 weeks, then you need to worry about diabetes and you also need to worry about adrenal suppression. And then you should taper off the drug slowly. If the drug has been given just for 7 days, 10 days in low doses, you don't need to taper off, you can stop immediately. If you are giving steroids to your patient and you are checking for glucose, check every second, third day. And especially don't forget to check the post lunch or evening or pre dinner values. Dr. Irfanullah raises a very important point. In a person with normal renal function, is there anything like too much vitamin C? So, sir, my traditional knowledge, information was that there is nothing like that, what you say. But now, when all this mucormycosis epidemic came, some of the theories were that we were giving too much of vitamin C to our patients and that we were giving too much of zinc to our patients, and these might have contributed to mucormycosis growth. That is why no point in giving unnecessary vitamin D. It will just go out through the kidney, but it might cause damage. Another question is, how do we adjust insulin levels in basal bolus and twice daily insulin? So let us go one by one. Uh, According to textbook, I should initiate basal insulin in any patient who requires insulin. If I am giving basal insulin, there will always be some other drug that is being given. It can be metformin, it can be sulfonylurea, DPP4, SGLT2 inhibitor, maybe GLP-1 RA. So, whatever dose of insulin I give at night, basal, will control the fasting glucose. So, maybe I gave glargine or degludec at night, 10 units. After 2 3 days, I check the fasting glucose, and maybe my target is 100. If I'm above 100, I increase from 10 to 12, 12 to 14, 14 to 16. I keep on increasing until I reach a normal fasting glucose, and the rough target will be 100 in most people. If I'm giving twice daily pre-mixed, then similarly, uh, for the dinner dose, I will check the fasting glucose. If fasting glucose is high, I will increase the dinner dose. If fasting glucose is normal, I will keep the dinner dose same. If fasting glucose is coming down or patient is getting hypoglycemia at night, I will reduce the dinner dose. For the morning dose, I will check pre-dinner values. So I will check glucose levels in the day also. But first of all, to set my dose, I will check pre-dinner. If pre-dinner is high or low, then I will increase or decrease the dose of the morning premixed. So remember to teach the patient, always change the previous dose, the preceding dose. Don't change the next dose, the coming dose. For basal bolus, there are two aspects to it. Basal insulin will control fasting glucose. So based upon fasting glucose, I will adjust the basal dose at night. For bolus, I have to check pre-meal and post-meal, pre-breakfast and post-breakfast, 2 hours. Similarly, pre-lunch and 2 hours post-lunch, and then pre-dinner and 2 hours post-dinner. The difference between these is called excursion or delta. So a breakfast excursion or delta breakfast, lunch excursion or delta lunch, dinner excursion or post-dinner excursion or delta dinner. Ideally, this should be less than 40. At the most, you can accept between 40 and 74. But if the glucose excursion is more than 74, it means we have to increase the bolus dose. If it is less than 40, you might want to reduce the dose also. But here for this, of course, you check the bolus dose, but also check the meal. How much carbohydrate was there in the meal? How much complex carb was there? What was the quantity? So we might get away by reducing the carbohydrates instead of increasing the bolus dose. Dr. Shrimandir Kumar asks a very tough question. How long does hyperglycemia last after COVID? So each patient is different. You can actually inform your patient that each patient is different. We don't know how you'll respond. Most people respond well, but we will be very glucovigilant. We will keep on checking glucose regularly in you. We can check HbA1c even after 1 month. Every 1 month also we can check just to see what is going on in the body. But until that time, that glucose levels remain high, please allow us to treat. This will help you recover faster from COVID-19. Deflazacort is as harmful as the other corticosteroids in terms of glucose control. So there is no extra advantage to be gained by giving deflacort. Uh, Prednisolone and methylprednisolone will be equally safe in diabetes mellitus. In all of them, you have to keep on checking glucose levels throughout the day and especially in the evening. Dr. Sanjay Mehrotra asks a question with which I face challenges actually in my practice. How significant is olanzapine-induced hyperglycemia? It is actually quite frequent in practice. Uh, be friends with the psychiatrists around you. They prescribe lots and lots of olanzapine. Just tell them to be watchful for increase in body weight or obesity, especially central obesity, and also to check glucose and lipids in their patients regularly. And you will be pleasantly surprised that many patients will begin to be referred to you. Do not criticize the psychiatrist or the psychiatry prescription because olanzapine is doing its job. When such a patient comes to you, tell the patient you continue with the antipsychotic therapy, but let us add some more drugs which will help the antipsychotic therapy help you better. And with this kind of a mindset, you will see that your interaction with your psychiatric colleagues will increase a lot. Other questions are also there, and we acknowledge Dr. Ajaypal Singh sir for joining us. Jazz Moharana is there. So uh, Jazz has also noticed that diabetes and obesity really worsen COVID-19 outcomes, and that is true. Sanjay Marathaji also asked a question about olanzapine, uh, and we've just answered that. Olanzapine does lead to a lot of hyperglycemia. Whether you see it in practice or not will depend upon whether you are good friends with your psychiatric colleagues and how well you have motivated your psychiatric colleagues to check lipids and glucose and waist circumference and body weight regularly in your patients. If patient has obesity, then that is treated with intensive behavioral therapy, diet and exercise. You can use drugs also. Orlistat is available, liraglutide injection is available, and recently semaglutide tablets have been introduced in the country for management of type 2 diabetes. But at higher dose, they can be used for management of obesity as well. The cost is a barrier, however. They cost about 300 rupees plus per tablet per day. So, but you can still inform your patients about these if required. Vinod Kumarji is also with us, and I think we've taken all the questions so far. But I would like to thank everybody for having logged in today. We have a few weeks more to go for season one of Diabetes Essentials. And once this is over, we'll be back with a bigger and better and more exciting, more enthusiastic version of Diabetes Essentials, season two. Do let us know what you'd like to see in that session, and we'll do our best to cover the topics that you ask us to. So I'd like to thank you all, and back to Team FDC.
Thank you, sir. I think today questions also tells us very clearly that it was a very in the moment session. That's why we got a lot of questions regarding COVID and diabetes, and very happy to see that you have taken all the questions. And that's the forte of our diabetes essential, where you come across not only with the practical knowledge as well as you also take the live questions. With this, I thank Dr. Sanjay Kalra with us, and we are looking forward for season 2 as well. Jai Hind.
Jai Hind.